who will be talking to us about her studies in children who are impacted by chromosome deletion of chromosome 4 on the short arm. To translate a little bit. Dr. Calhoun has been a part of our clinical group now since 2012, which is sort of like, wow. And joined us after doing a thorough and intense fellowship at the University of Utah after she was chief resident at the University of Iowa in pediatrics. So well-trained as part of our group. And she'll be joined by Amanda Lortz, who is the leader of the family group for this condition. So without further ado, I thank Amy and Amanda for sharing their information with us.
Okay, is the lapel mic on now? Are we good? Yes, no? Okay, great. So thanks for introducing me, so I really appreciate it. So Amanda Lortz is the executive director of the 4P- support group, which is the family support group for Wolf-Hirschhorn syndrome and related conditions, and she'll be talking in just a few minutes. So we wanted to talk a little bit today about the collaboration that we have going between the parent support group for Wolf-Hirschhorn syndrome, 4P- support group, and myself and some other academic geneticists, and industry group that provides cytogenetic testing and the utility of this type of collaboration. Disclosures. So Lineagen has provided some support for our research, and they are a for-profit genetic testing company, and they've never provided me directly with anything, but they do help us out with some financial and sort of personnel and logistics support for some of the research that's happening. So I want to disclose that. I have no other important financial relationships of any type. So I wanted to start with my credits instead of ending with my credits because I totally am not doing this by myself, and I'm actually kind of a small piece of it. So the first people I want to thank are the 4P- support group. So when I was a fellow, Dr. John Carey, he's in this picture here. Oh, do I have a little pointer? This is what, it's not working. Okay, that's Dr. John Carey there. He's my mentor, and one day when I was starting off my fellowship, he says, you gotta come, there's this really great meeting, you gotta come. And it was the 4P- support group meeting. It was just amazing, it changed my life. So I have just loved, I'm the chair of the scientific advisory board for this 4P- support group, and it has just been the most awesome thing I've ever done. So, and Amanda, of course, is executive director, and she has outstanding organizational skills. And then my mentors, and they are also research collaborators with me. And that's the symbol for the University of Utah. So that's what that is. And then our collaborators at Lineagen, led by Dr. Ho. So a little background, because honestly, this is a rare disease, and if you haven't heard of it, that's normal. So Wolf-Hirschhorn syndrome, it's a congenital chromosome disorder, and it's caused by a missing piece of the short arm, which is the P arm, chromosome 4. Here's our incidence. It's probably not right, just like the published incidence of all rare disorders. So, little terminology thing. The difference between Wolf-Hirschhorn and 4P-. So a lot of people use it interchangeably, but I don't. I have a little bit of a difference. So Wolf-Hirschhorn syndrome is a specific subset of patients with deletions of 4P. And 4P is the big picture group. So there are people who have 4P- who don't have Wolf-Hirschhorn syndrome. They won't meet clinical criteria for Wolf-Hirschhorn syndrome. If we don't know the true incidence of deletions in 4P. So, okay, why is it called Wolf-Hirschhorn? These are the two first published patients. So this is Dr. Hirschhorn's patient and Dr. Wolf's patient. And so you can see that they were actually published a few years apart, but they were actually sort of reported initially right around the same time. And this was the very first chromosome microdeletion syndrome reported in the medical literature, and in the 1960s. Okay, a little bit about chromosomes, just quickly. The P arm is the short arm. P is for petite, French for small. The long arm is called the Q arm. Now, cytogeneticists are completely crazy. So it's Q because Q and P go together, not because Q is short for the French word for long, which I don't even know what the French word for long is. But I actually think it's confusing because P's and Q's look too much alike. But anyway, that's the centromere, which is the center. And then the telomeres are the tips. And the most common thing to see in Wolf-Hirschhorn is the terminal deletion. So it's a picture of a terminal deletion, or the telomere of 4P, the short arm is missing. And then another common cause is a translocation. And so you can see they just swap tips. And then the parent passes it along to their kid. So you get trisomy for chromosome 8 and monosomy for chromosome 4. So they have a deletion of 4P, but they also have an extra tip of 8P. And I didn't use 8 for no reason. It's actually the most common translocation that we see. So I didn't just throw that in there for fun. Okay. This is a normal karyogram, or we can call it a karyotype, but the picture, when you actually have a picture, it's a karyogram. So the karyotype is 46XX, meaning normal chromosome constitution. Oh, and I do have down there, if you need to order it on Epic, the order is chromosome blood high resolution for future reference. I think they put the slides online, so if you're trying to figure out how to order this. Here's a picture of a karyogram that, as you would see in someone with Wolf-Hirschhorn syndrome. This study can detect both balanced and unbalanced translocations if they're big enough. Here's a close-up. So this is actually really hard to see in a standard karyogram. I know this doesn't project very well, but see, here's a normal chromosome 4, and Dr. South is the cytogeneticist who's affiliated with the 4P- support group, and she's a fantastic cytogeneticist. She calls that the cotton ball. And if you look at this one, you can see the cotton ball is missing, but that's very subtle and hard to see. Here's a fish study. So this is another way of getting at it. Also, mostly because fish is pretty, so we love to show fish. So fish is done with a fluorescent probe that's targeted to the critical region on the chromosome. And the normal result is 2 red signals. So you're supposed to have 2 copies. And this would be a positive study. So see, critical region is present there and absent on the other 4. And if your patient does not have a deletion including the critical region, this test will miss it. And patients who have deletions that do not include the critical region can still have a clinically meaningful deletion of 4P. So we actually don't use this study much anymore, but there was a period where this was actually the best study we had for this condition. Okay, this is the best study. So here, up there, it's a very subtle deletion at the tip of the short arm of chromosome 4. This deletion would not be visible. Remember, I was showing those karograms on the previous slide. You would not be able to see this on those. And this study has about 12 names, maybe not 12, probably closer to 5. So you can call it an array comparative genomic hybridization or chromosomal microarray, and then I've got some of the acronyms here. Here's the EPIC order for this, in case you need to order it. It's really important. This study cannot detect a balanced translocation because this is done looking at little pieces of DNA. So you don't know where it's located. You just know whether it's there or not. So that's really just an important thing to remember about this particular study if you are for some reason have to order it. Our lab also offers a combined order, so you can order CGH with limited blood high resolution. So you'll actually get this, and then if there's something funny, they will also do a karyotype to double check, which is my preferred study for an unknown patient. Okay, and this is a little close-up of what you're actually getting when you do a CGH. So these little purplish dots up here are little probes, and they're targeted to specific locations in the DNA, and we're doing dosage. So 0 is the normal number of hits. So 0 is the normal dosage. That's just the way they do it. And as you can see, we're coming along, it's at 0, and then all of a sudden it drops below 0. So this person only has one copy at all of those locations instead of the normal 2 copies. And so you get this. This allows you a really precise idea where the deletion starts, which is really useful for us for our genotype phenotype studies. Again, this won't detect a balanced translocation, only an unbalanced translocation. So there's a lot of variability in 4P deletions. This is a nice slide from Dr. South. I had suspected this for a long time, but Dr. South has been working really hard on this. And outside of family members, it looks like no 2 people with 4P minus have the same deletion. There is not a recurrent deletion. This is really different from some of our other microdeletion disorders like 22q or some of our other really common microdeletions. No 2 people are exactly the same. The other sort of caveat here is that traditionally we thought of this as a deletion of the entire tip or a telomeric deletion, and these people all have telomeric deletions of varying sizes. But we do have some patients where the tip is not included. And so that was sort of a relatively new discovery. The other thing was originally we thought that there wasn't a very high incidence of translocations, largely because of the limitations of the technology. But as Dr. South has looked into it more, up to 40% of patients have a subtle translocation. Almost all of these are new in the kid. So when we think about translocations, unbalanced translocations, and balanced translocations, a lot of times they're inherited from a parent who's balanced, like I showed you in that slide where I was showing you how the translocations work. But in the context of 4P minus and Wolf-Hirschhorn, most of our translocations are not inherited. And like I said, most common is 4P, the second most common is with chromosome 11. And unfortunately, this makes genotype-phenotype correlation. So me looking at the results of the testing, and why do we actually do genetic testing? Not just for fun, because we like to look at these word diagrams. It's so I can tell you something meaningful about your patient. If you say, will my patient have malrotation of their bowel? Will my patient have kidney failure? Right? So that's what we're actually looking at. What does this mean for the patient? Well, these subtle extra pieces in concert with the missing piece makes this much more difficult. Okay. And because of all the different sizes of the deletions, this is a true contiguous gene deletion syndrome. There's not, some of our deletions syndromes have a key gene that if you just hit that gene, or you can even mutate the gene and get the same phenotype as the deletion. But there's no one key gene for Wolf-Hirschhorn. So it depends on a whole group of genes for the phenotype. Okay, a little bit about the clinical findings. There are 4 key pillars of Wolf-Hirschhorn syndrome. The first is the distinctive facial features, or the Gestalt, the way the face looks. Gestalt is German for form or figure, and it's the word that we just morphologists love to describe just the way you look. You can even say Augenblick Gestalt, which means glancing overview of the face. And then there is a growth disorder, which is really critical, and some component of developmental delay and intellectual disability and neurological problems. So here's a picture of a bunch of kids with 4P deletions, and you can see there's some significant variability in the facial appearance. But key pieces of the facial appearance are that the eyes are wider spaced, and they also have these beautiful arched eyebrows. See the beautiful arched eyebrows? And then the mid part of the nose is a little bit broader, and this part of the face is small. So you get kind of, it's a little bigger through here and then a little smaller through here. And you can see some of these kids have a little bit bigger, and then these kids have a little more subtle deletion, and you can see the facial, they do look alike, but it's a little more subtle in these kids than it is in the kids in the top row. Okay, growth is a huge problem. It's universally very poor. It starts before kids are born, It's a symmetric growth problem, so the head is also small. So the body length, weight, and head are all small. The weight tends to be the most affected, so the kids will be really skinny. And then it starts before the kids are born. And some of the parents have told me that they've had their due date moved because they thought the dates must be off. And so, but they will start, so it'll be, a lot of the patients are IUGR before they're even born. And then this is a huge, growth is an issue lifelong. And it doesn't, for the GI people, I see we have lots of GI people, doesn't fully respond to caloric supplementation. So we put G tubes in, we can put tons of calories in them, they'll still be skinny and small. So that's an important thing to remember when you're managing them. Developmental delays is a famous part of the condition. We do have a few patients who have normal cognition. That's not typical, but it can be seen. If you read the textbooks, the opinion that you'll get on the development will be that there's very severe developmental impacts. That's less so in our actual life experience, although most of our patients do have some developmental impact. Lots of our patients were told their kid would never talk, never walk, never do any of those kinds of fun things, but we have lots and lots of patients who can do all of those things. One of my personal patients, his favorite subject is math, and he told me that at our last checkup. The other interesting thing about Wolf-Hirschhorn and 4P minus is that developmental progress is lifelong, so they continue to make progress through their entire lifespan. We have some adults who, at our last meeting, mom said, hey, he just learned how to walk. He just started talking. And so if you see developmental regression, we got to do some additional workup because that's not typical. Neurological problems. Seizures are a huge issue. Almost all of our patients have seizures. They can be really difficult to manage. Status is a big deal, and it's sensitive to fever. And even our patients who don't have seizures may have abnormal EEG findings. And this is actually one of the serious causes of morbidity and mortality in our population. We've had many patients pass away in status. Okay, just quick on some other common problems. About 50% of patients can have a congenital heart defect, but it's usually not a huge deal. They're almost always an ASD or a VSD that's very repairable. So in this particular chromosome condition, the heart is not a huge cause of morbidity and mortality for most of our patients. They often have hearing problems. We see both kinds of hearing problems, both because they've had chronic otitis and also there can be a sensorial hearing loss, which can be progressive. This is one of the things we need to monitor moving forward. A lot of our patients have eye problems. This is really variable. You can see colobomas, you can see nearsightedness, sometimes even more serious eye malformations. We have a few patients who have microphthalmia. There's also dental problems. All of the parents that I've asked have said the teeth came in late. Every single one. I didn't ask everybody, but everybody I've asked has said the teeth came in late. Cleft lip and palate are also pretty common. Okay, now Amanda's turn.
I can't move around like Amy, so I'm going to be stationary. We know that for many of you, you're probably learning about 4P minus for the first time today and thought it was equally important that we also share the 4P minus support group with you. Many doctors are surprised that there is a patient organization out there for such a rare syndrome. We've actually been around since the early 90s. Our mission is to serve our membership by providing information, education, and support, uniting families, researchers, and professionals, and promoting awareness and understanding of 4P minus syndrome with Wolf-Hirschhorn syndrome as the main condition and the related fourth chromosome abnormalities. So we are a nonprofit organization for Wolf-Hirschhorn syndrome, but since there are patients that aren't, they don't fall into that WHS diagnosis, we also invite anybody with a fourth chromosome abnormality, whether it be 4P minus or 4P plus. So if you do find patients with any fourth chromosome abnormality, you can send them our way. We estimate there's approximately 2,000 individuals around the world living with Wolf-Hirschhorn syndrome. That number is based on our membership. We have over 800 members. There's also parent organizations in the UK, Italy, and Australia. So we've combined those numbers, and then knowing that not every family wants to join a parent organization. For many reasons, parents they don't want to be involved. So that's where we came up with the 2,000 estimate. And I wanted to point out, of our 800 members, over 250 have a child over the age of 21. And that's very significant when we're talking about a rare syndrome, because that shows us that we need to begin researching on life prognosis with our patients and what's happening to them in adulthood, because obviously they are able to live into adulthood when before it was a grim prognosis. And down here at I'm sorry, I didn't advance my slide. Do I do this on here, Amy?
Push down there. Sorry. Just push this on.
Okay. Down here on the bottom left is from our 2014 National Conference, and these are all of our adults that attended the conference with us. And I did want to point out the two ladies on the right. Both are my age 35 or over, and I share birthday month and year with the lady on the top there. So I know a lot of people haven't seen somebody with 4P minus before, and I'm sure you haven't seen somebody in their 30s. Our organization has found that by hosting a national conference every 2 years, we are able to effectively accomplish our mission in one single, often life-changing event for families. We hold them every 2 years, an even-numbered years, so this summer will be a national conference for us. And we bring together families, researchers, clinicians. We have a multi-track meeting, so families will attend sessions on learning about 4P minus, learning about seizures and nephrology. We also have sessions on therapies, whether it be horseback riding, music therapy, and then we also break out sessions for just mom-to-mom time, dad-to-dad time, which is very important for the dads to be able to discuss privately, and then also for extended family members. We hold workshops for caregiving, and down here at the bottom I just put a quote because we often hear from families that nothing compares for them being able to meet other families in person. You can do a lot online now, a lot of Facebooking, emailing, but really families find that coming to a national conference and meeting other families is where they learn the most about their child by seeing somebody else's child, especially for those with young children. And I did want to include a picture. This is from our 2014 conference. We had our highest attendance. We had over 90 families. So definitely I would encourage, if you've ever run across a patient, whether they're interested or not, at least to share our organization with them, because over half of these were first-time attendees. And I know that they'll be coming back to your next conferences. We also provide a private online discussion forum, quarterly newsletters. They're welcome to give us a phone call or provide us with their number, whether it's I can answer a question for them or they have a little bit more complex question. I can refer them to one of our genetic counselors who's on our advisory board. And we also offer regional gatherings, so if somebody can't attend a national conference, whether it's too expensive, too far away, the years opposite of our national conference, we hold smaller regional gatherings. On our website, we have the webinar we did with the National Society of Genetic Counselors. I know Amy spoke, Dr. Sarah South spoke. It's right on our front website. It gives over cytogenetics. It gives parent stories. It's a great tool, so I would encourage you to use it if you ever wanted more information than just this grand rounds on 4P minus. We also have an awareness day, April 16th, 4P 16, if you get that. We now have a patient registry, and we actively look for research opportunities and then pass that along to our community. We have a scientific advisory board comprising of Dr. John Carey, Dr. Amy Calhoun, Dr. Sarah South, Dr. Agostino Battaglia, and several others. And in conjunction with our national conferences, we also hold a research workshop. Tends to be invited only. It's really geared to those who are actively researching in 4P minus, but we do, any professional that's looking to join our team and research is welcome to attend. So I put this little quotey thing up here, and I'm sure many of you probably have found that to be true, that as myself, a parent, I've probably done better research than what was available to me when my daughter was diagnosed. And I don't mean that rudely. It's just, I think when you don't have those answers, you're going to search for them. Even as a doctor, we were talking about this last night. If you don't have the answers, you will spend a few hours, trying to find those answers. And that's what our parents did. Our founding parents did. They saw that there were other children living with 4P minus, and since they didn't have a lot of information, they developed a biographical form. What are your child's seizures like? What are their dental issues? They put together these bioforms, and then they shared them with one another. And they began learning a lot about our syndrome, passing it along to Dr. Carey. And then when I came along in 2006, I was reading hundreds of these bios with all of this great research information. But there wasn't a great systematic way to be able to send that information to researchers, to doctors, so we could publish these cases. And that led us into last year, finally, launching our international patient registry. It is international, so as long as the family is comprehensive of English, they are welcome to enroll. We provide research opportunities with clinicians, professionals. As long as you have an IRB approved study, you can access our database or our registry. So far, at the end of last year, we had 57 enrolled participants. We have 22 that started the process and didn't quite finish it that we're going to try to capture. But that's a good start for us. So, and we're already seeing some fruits of our labor, which Amy will share. You ready?
So, as Amanda was sort of alluding to, when she came on as the president of the support group had really decided that they wanted to push harder to get some more research done, because this is a rare condition and there just wasn't enough data and there wasn't enough stuff out there. And so they decided they were going to, besides doing some of this mutual support and social stuff that they had been doing for a long time, they wanted to bring in more physicians and more researchers and get more research done. And to that end, they got Dr. Carey hooked in, and of course he hooked me in, and then they were also able to bring in some researchers from Lineagen, which is this this genetic diagnostic testing company that's located in Utah. And what's really cool is we finally, why collaborate? So why did we put together this collaboration? Well, it's a rare disease. So I personally follow here 2 people with this condition. And that's pretty true for other academic geneticists around the country. They do not, in their own practice or even in their own center, because between me and my partners, what do we have, like 5 or 6 or something like that? So not enough to do research. That is not enough people to do research. And so you can't do a single center study. And even sort of your typical multi-center of maybe 4 or 5 or 6 centers, you're still not going to get enough people to do a study that can have any statistical validity. we've also run into that we're not a funding priority. So I've tried many, many times, and Amanda has tried many, many times to get grants, even small grants, seed grants. We always get turned down because people aren't really impressed by it's a rare disease and what are you really going to do? It's chromosomal. We're going to give our money to somebody else. So it's very hard to get funding for our research. And so finally, we put together this collaboration, bringing academic geneticists with the research skill set, because we're trained to research, and the parent support group. They had the drive, they had the direction, they had the research they wanted done, and they also had the people to do the study, and then also were able to get some industry, which is Lineagen, for just resources. Because prior to that, it was like me and Dr. Carey out of our own pocket, whatever research, if I needed to make a survey, I printed it myself, and stuff like that. So they were able to provide us with some resources to get some stuff done. So we got something. We actually got something. This is hot off the press. This is just about to be published in the Journal of Medical Genetics. We just got the official little blurb saying it's getting published. So we found a new seizure susceptibility region. Previously, and I'm sure you do not remember the slide where I had a list of all the genes that are in the critical region, because who would? I wouldn't. LATM1 has always been our leading candidate for seizures in Wolf-Hirschhorn syndrome. And this is a great candidate gene for many reasons, but it's actually a mitochondrial gene, and it controls calcium homeostasis and ATP generation and oxidative stress prevention in the mitochondria. So it was always a good, from a sort of what does it do perspective, mechanistic perspective, is always a good candidate. It's also right in the middle of the critical region. So another good reason that it was always suspected. But, so Dr. Ho said, what's our first target? So like I was saying earlier, huge piece of morbidity and mortality in Wolf-Hirschhorn syndrome is the seizures. And it seemed like a good target because do you have seizures? Yes, no. How bad are your seizures? Yes, no. Is a relatively easy piece of information to get from patients. And so we recruited 48 patients, all from the support group. Most of them 90% had seizures, which is the exact reported incidence in our population. And by very careful study with these high-resolution microarrays, they were able to localize a site for seizure activity to the terminal 751 kilobase pairs on 4P. This region correlated more tightly than haploinsufficiency for LATM1, which was our original candidate for what causes seizures, why do our patients have seizures. There's a p-value. I'm not really that good at stats, but that's a pretty decent p-value. We were also able to look a little bit at seizure treatment, which of course, this is why we do this, right? We want to know how to help. I mean, it's great to know where the critical region is, but we really want to help. And so we were actually able to get some data on ranking some of the seizure medications for efficacy. So no surprise, Keppra was the favorite. And no surprise, phenobarb has a lot of side effects. And this fits with some of the trends that we were getting just from talking, because Amanda and I do a lot of talking to the families about what's working, and then they just tell us stuff, spontaneously bring stuff up. So this actually matched with my gut feeling, which made me feel better about my gut feeling. So after they got that region from our data, then Dr. Ho and her compatriots combed through the literature and compared the critical region with cases in the literature. And we're able to cut this down more to 197 kilobase pairs. There are 3 genes in that region. That's actually like a dual number. Here they are. ZNF721. We don't know what it does. It localizes to the embryonic limbs, so it probably does something to involve that. PIGG. This has no known human disease phenotype. There's always a risk there's somebody here who actually studies this, and I can't even say the glycosyl phosphatidyl inositol anchor. So this has so this is involved in that. And then ABCA11P is a pseudogene, we think. Probably doesn't do anything, although you never really know. Here's another picture. So here's our 4th chromosome here. Here's our centromere, just for geographic. See how terminal this is? So here's our genes. And here's PIGG over here. This is adapted from the genome browser if you ever want to make one. Okay, so after looking at that, PIGG is our new candidate gene. So PIGG is one of 26 members of this group that I can't say. What this PGI anchor does is it hooks important proteins to the plasma membrane. And so it seems like it's important, so that's good, because if it wasn't important, it probably wouldn't be involved in seizures. We can't prove at this point that it causes seizures, but it makes sense because in fish, this is important for our voltage-gated sodium channels to go where they're supposed to go. And I don't see any neurologists, but voltage-gated sodium channels have been implicated in a lot of different seizure conditions. So that's a good connection. And then, so PIGG gloms together with a whole bunch of other proteins, and a bunch of its friends. See this PIG. There's A, B, C, D, E, all the way through T. I don't think that's the last one. I think there's a PIGW too, so I'm not sure. It might make it all the way through the alphabet. So several similar proteins have been associated with seizures in genetic conditions. So it's pretty plausible. So that's actually like a real result. We've achieved something. Okay, and then but we're not done. We're still working on some additional stuff. The holy grail of Wolf-Hirschhorn is genotype-phenotype correlation, like I was talking about. So no 2 patients have the same deletion. So if I look at your deletion, I should be able to tell you something about your clinical phenotype, right? Theoretically, ostensibly. It's been really, really hard. So many smart people have worked on this. Dr. Carey forever, Dr. South forever, Dr. Battaglia forever, Dr. Marcella Zolino, she's also in Italy, Dr. Battaglia's in Italy. Lots of super smart people have worked on this for a long time. As I mentioned before, no 2 unrelated individuals have the exact same deletion. So it simultaneously gives us more information and makes it harder. And then, of course, as I was talking about before, many individuals have a second copy number change. Okay. How are we doing time-wise? We're good. Okay. So here's this is a sample from our patient population that Dr. Ho is working on. And she did a little scatter plot, preliminary scatter plot, between deletion size and the number of features reported by the patients on a scale of features, and it does loosely correlate. This is just me putting together everything I found from looking at all the smart people that have worked on this. Part of this is from this article, but some of this is also my work just because I know. So there's some preliminary stuff. So what we do know about genotype-phenotype correlation, it's likely that overall deletion size is correlated to severity, although that hasn't always held up 100%. You'd think that would be obvious, but it's amazing how unobvious some of these things are. And then we have been able to suspect certain genes for certain parts of the phenotype. But we don't know. There are so many genes in the critical region, we don't know what they do. And then we also don't know what the duplications mean. Like every single person who ever talks during rounds, this line, right? Everybody says this. We need more research. But it's true. We do need more research because we do not know enough. And our collaboration is actively working on this. All right. Isn't she beautiful? This is from my favorite blog, Star in Her Eye. wordpress.com. This is they're members of our support group. But if you have any interest in just the life of people with disabilities, she speaks beautifully. She's an incredible writer. She speaks beautifully to issues of having a child who's nonverbal, issues of having a child who's growing poorly, issues of having a child with poor mobility, issues of having a child who's different, neurodevelopmentally different, and having a child who's neurotypical. And she kills me every time. So, and also, isn't she beautiful? Any questions? Sir. I'm a little hard of hearing, so that's why I'm coming close.
Two questions.
Yes, sir.
You told us the what. Do you want to speculate about the why of thanks. You told us
I don't think that's working. Yeah.
you told us the what.
Uh-huh.
The question is why? What are you speculating about the why? Not only of the changes in 4P, but why they so vary. The second question is, one thing that would be very interesting is, do you have a curve of when the diagnosis for these patients is made? In other words, how many of them are recognized soon? How many are not recognized till they're teenagers or later?
That's a really good question. So 2 questions. Summarizing it a little bit. Why do we have such variability in our deletions? That's likely because there aren't any of the regions on the genome that we see in other microdeletion syndromes that predispose to deletions and duplications. So the 22q is the single most common. It causes velocardiocell George syndrome. It's the single most common deletion in the human genome, and there are these repetitive elements on either side that cause that piece to just fall out really easily. We don't have any of those elements on the short arm of 4, so that's why they're all different. And I'm not sure why 4 is a little more predisposed to losing its tip than some of the other chromosomes are, but it might not be. It might also be that, because one of the things we see with chromosome conditions is actually the ones you see are the ones that are less serious. So if you lop off the tip of another chromosome, it might not be survivable. So that's sometimes there's that piece of it too. But the short answer to that is I don't have any idea. And then what was the second question again?
The second question had to do
with
age.
how long it takes to diagnose. Huge range. We have every once in a while we make a prenatal diagnosis. That's actually really challenging. Although the prenatal diagnostic technology is getting a little bit better. I have seen patients diagnosed prenatally based on ultrasound findings. If you get an incredible ultrasonographer with someone who knows how to do the facial gestalt, I've seen people get the facial appearance off of a prenatal ultrasound. That being said, most of our patients have pretty significant delay. Amanda had a significant experience with delay in her daughter's diagnosis.
And I think my daughter's delay was she doesn't represent the facial features as well as some of our other patients.
Yeah, she has
she looks a little bit normal, but she was smaller. Her seizures were very hard to recognize. She had myoclonic jerks, and those aren't necessarily considered seizures in infancy.
Yeah.
And she was small. My due date was pushed back. We had all of those little puzzle pieces, but her first karyotype was normal. And it took us almost 2 years to get to a doctor that saw her have a seizure in clinic and knew that I wasn't crazy, and then sent us on to genetics. It just took that long because she didn't look it. And we've talked about, removing that terminology Greek warrior helmet from Wolf-Hirschhorn. I've been told by some geneticists in other countries that they use that tool a lot because they don't have the DNA testing in their country necessarily, and they'll use that as their diagnostic tool. But here in the U.S., we're seeing more patients that have very subtle facial features, and we can't go by that alone. And I think that's what really delays the diagnosis. If their karyotype comes back normal, is their doctor pushing to go ahead and do a FISH or a microarray?
And of course, the other piece is with all dysmorphology syndromes, you can only really spot the facial features if you've seen it before, and it's rare. So that makes it really challenging. Oh, Carol has a question.
So you probably answered this somewhat, but now with new prenatal technology, the NIPT or non-invasive prenatal diagnosis, the last few years they've been adding microdeletion syndromes, including the 4P minus. Are you seeing any more people come through your support group that have a prenatal diagnosis?
Because we work with Dr. Sarah South, and we've been approached by a couple of studies that our members could participate in. And she was very wary of those studies. So we, as an organization, have yet to participate in those studies because there were so many false negatives. And she just didn't feel that the testing has come along as far to really detect 4P minus, and didn't want that stigma.
Yeah, and we haven't had any. The prenatal diagnoses have been from suspected on ultrasound, and then the ones that I know of are actually have microscopically visible the big deletions, and so they just had anomalies, got an amnio, did a karyotype, and saw it, and of course that would be only the most severely affected. So we haven't had any of our subtly affected, and of course so far we don't have anybody who's had a true array done, because you can do those prenatally as well, and so far we haven't seen that, and nobody's had it picked up on NIPT that I know of.
Yeah, and we have had, I do know personally, a couple mothers who had amnio, and it was not detected either.
Most of those are karyotypes. Yeah, so yeah, you would hope the prenatal arrays could pick it up, but we have yet to have anybody, and I don't know about any with NIPT, but that's a really good question.
If there are no other questions, I'd like to thank Amy and Amanda for sharing their knowledge. That was wonderful. Thank you.
Thanks.
Wakes people up too. It's really effective on the medical students when they're sleeping, and I start stopping across the front.